So, welcome to our fall professional speaker series for October 2024. Today, we are so excited to have Dr. Joe Cavallaro join us. Um, Dr. Cavallaro is a physical therapist with the National Guard. He's coming to talk to us about rehab and performance in the National Guard. So, if you didn't see his bio, I'm going to read it for you guys because he's got some fantastic stuff in his background. So Joe is a doctor of physical therapy and an on-site human performance specialist with the Massachusetts National Guard, where he provides support in injury management and prevention. He is a 2013 graduate of Northeastern University's DPT program. He's board certified in sports physical therapy. He's a certified strength and conditioning specialist through the NSCA and a USA triathlon coach. He has worked with the Boston Celtics and the Indiana Pacers, Premier League lacrosse, and other professional triathletes. He and his wife are active in the running and triathlon clubs and can be found year-round in the White Mountains of New Hampshire, hiking, climbing, or ski touring. So I'm going to give Joe the screen sharing privileges here as best I can.
Excuse me. Thank you. First off, thank you for inviting me to speak with you all tonight. Really excited to share my experience and my role. Okay, you should have the presentation now, and I have the
Yeah,
presentation. Is that right?
yeah,
Perfect.
looks good.
Okay, awesome. Thank you. Sorry about that. So my name is Joe Cavallaro. I'm a physical therapist, and I work full-time for the Massachusetts Army National Guard. Um, our setting is what we call tactical physical therapy. In a few minutes, we'll get into what tactical physical therapy is, what that setting looks like, what the demands of our individuals and our professionals that work in there look like. But I'll give you a quick background update on who I am, where I come from, and kind of how I got to this point, where I'm at right now. So I graduated from Northeastern in 2013 with a PT degree. During that time, I was fortunate through our co-op program to get connected with the head athletic trainer for the Boston Celtics. And that was my first introduction to the professional sports world. Going to physical therapy school, working in sports, primarily professional sports, was initially a goal of mine. And so when I found the opportunity to get connected while I was in school, I was considered myself very fortunate to be able to leverage those experiences. Moving forward, I ended up taking a clinical with the Indiana Pacers, and then I spent some time with the team following that clinical rotation. After graduating from Northeastern, I went into private practice and started to work my way back towards working in professional sports. That was still my goal at the time. What I had learned after working with the Celtics and working with the Indiana Pacers was that most individuals at that time, back in 2013, working in a physical therapy capacity, also had athletic training degrees. I don't know if that is entirely still the case. I don't believe it to be entirely still the case, but at that time, the Celtics, the Pacers, and the other teams that I was interviewing with, talking to, they were all looking for people who wore dual hats and were able to work in both capacities or in both lanes. At that point, I had gone to Northeastern. It was a direct entry PT program, and so I needed to continue to look a little further down the road to figure out how I could add to my skill set so that I could get back into that role. What was communicated to me was that I needed to either have an athletic training degree or board certification in sports physical therapy, because that included similar content in terms of primary response to acute injuries or acute medical emergencies. And so that was the criteria we needed. And so I moved into private practice after finishing school. And while I was there, I worked for a number of different private practice clinics, mostly with a sports medicine focus, while I worked towards getting my SCS, or that board certification. I spent about 4 or 5 years working in private practice, and then got heavily involved with working with runners and triathletes. That was a group that I was particularly interested in working with. I was seeing a lot of patients in that, coming from that background and trying to get back to that sport from beginners, high school athletes, college athletes, to um, recreational, serious amateurs, and some professional athletes as well. What I found at that time was that there was a little bit of a gap between where I was able to take those patients in the clinic and what some of them needed in their return to sport. So I started full spectrum physical therapy, which is uh, was my private ended up being my private practice, but started out as a coaching business, and that was coaching for runners and triathletes. Got my USAT certification at that point, which is USA Triathlon Level 1, so I could help coach triathletes and better understand what some of my athletes needed. At that point, I started working with some local professional triathletes who were training out of Massachusetts and Southern New Hampshire and needed to better understand what their demands were. Um, Over time, from coaching, that grew into working more with patients, so it became a private practice as well. Then COVID hit, and that kind of threw a huge wrench in my plans and my goals. And so I ended up working part-time or per diem and part-time at skilled nursing facility and independent living community, which was actually a pretty great experience for me. Expecting someone who thought that, hey, I wanted to get into professional sports, I world kind of shifted on me a little bit. Um, wasn't seeing as many patients through my private practice as I wanted to. Needed to be able to continue to um, pay the mortgage, pay the bills, and all that. And so I needed to find additional work. So I found this additional job and realized that I had a lot of these skills from school that I was able to lean on, and to be able to line them up with a lot of what we did in the sports world. A lot of it's very similar, just on a scaled basis. So that was pretty eye-opening. While I was doing that, I was still looking for opportunities to go back into the professional sports world. An opportunity came up to work with MARSOC, which is the Marine Special Operations Command, down at Camp Lejeune in North Carolina. That's not on the list because ultimately we turned that position down. Family and I decided not to move and that we wanted to stay here in the Northeast. Shortly after that, um, I got in touch with O2X Human Performance, which is the company that I currently work for. They were hiring for a program with the Massachusetts National Guard, and they were looking for somebody to take on an annual contract there. That was in 2000, that was 2021, and now I've been with the Massachusetts National Guard for the last 3 years. Along the way, through that course, I had to decide if athletic training or the board certification in sports was the pathway I wanted to go. And at that point, I kind of weighed looking at residencies, I weighed going back to athletic training school, and I weighed going for the board certification on my own. Based on where I was at the time, there were not a whole lot of sports medicine residencies available. And so I chose to sort of create my own residency approach where I was going to lean on the experience of a lot of my mentors. So I reached out to strength and conditioning specialists that I had worked with in the past. I reached out to athletic trainers that I had worked with in the past and experienced physical therapists from the sports world that I had also worked with in the past. And so I got all of the hours that I needed. I spent a lot of time communicating with them, going over cases, and making sure that I had all the nuts and bolts while utilizing a lot of the resources that were available for study materials. And in that sense, I kind of built my own residency. Fast forward there to 2024, I think there are a ton of sports medicine residencies available out there. If I were to do it again at this point, I would definitely be looking into some of those options. Um, while I was working in professional basketball, one of the shortcomings that I also noticed for myself as an individual was that I didn't have a strong background in the strength and conditioning field. When I started working with the Celtics, I spent a lot of time in the training room, a lot of time with athletes doing our physical therapy treatments, whether they were playing and being managed for injuries that they were able to play through or rehabbing injuries. I was really separated from the return to sport process, which in that organization was primarily owned by the strength and conditioning coaches. And for me, I felt like there was a really big gap in my knowledge base and my ability to help athletes return to a high level of performance demand, whether it was strength movements, power, plyometrics, jumping, sprinting, change of direction. I had a decent base knowledge in that from my PT education, but I felt like bridging that by going into the strength and conditioning world, getting the NSCA certified strength and conditioning specialist would help me better speak that language, better understand what some of those demands, training needs were, and help me better collaborate as part of a multidisciplinary team with the other individuals. So between myself as a PT and the strength and conditioning coaches on the team. So currently I work with O2X Human Performance with the Massachusetts Army National Guard. My role there is, or my title is what's called Injury Risk Reduction Specialist. And I also work with O2X as a workshop instructor or a consultant. So they have an additional number of contracts with different organizations from fire departments, law enforcement, federal law enforcement, and Department of Defense. That includes the Army, Army Reserves, Navy, Air Force, all these different organizations that they work with, where they either provide, um, uh, instructional seminars on human performance, where they help bridge the gap and educate the individual service members, or they provide consultation where they put a specialist, a physical therapist, athletic trainer, a strength and conditioning coach, or a dietitian on site with the organization for a short period of time to provide consultations and direction for the individuals. So over the last 3 years, I've been able to work with a number of organizations from those different fields, from the Department of Defense. That includes the Army National Guard, the Air National Guard, the Army Reserves, the Navy, number of different fire departments, local and state law enforcement, as well as federal law enforcement, particularly the U.S. Marshals Service. So over that time, spent the last 3 years prioritizing the Army National Guard, and a lot of that time learning about these additional tactical populations and the demands and the needs that they have. At O2X, we talk about 3 pillars of performance. And so physical therapy falls into what we call the sweat domain, but we look at the eat, sweat, and thrive domains. So those are our 3 pillars of performance. And all 3 of these domains really impact our ability to perform and remain healthy throughout our career, or throughout the career of the individual serving in these roles. Our eat category, that focuses on our individual's nutrition, whether it's their nutrition for performance or nutrition as they're going through recovery, how they're managing that. That's the quality of the food they eat, the quantity of the food they eat, and the timing and the way they approach that. Sweat, that's our physical readiness domain. So it's our training. How are our individuals preparing for their jobs? Also how they're recovering from or managing the injuries that they might sustain while operating as a tactical professional. Thrive, that's our last component, and that looks at stress management, coping abilities, resilience, mental performance, sleep, and all of we say it's everything above the neck, really. So everything going on in our headspace and how we're managing both the stressors that we have to face at work, or that our individuals have to face at work and at home. The 5 main areas we look at, or we talk about, our sleep, our stress management, that nutrition, hydration, our mental preparation, and our resilience falls into stress management and preparation, and then our conditioning, or physical resilience. When I go out and talk with our soldiers, or go out to any of these organizations from a teaching perspective, one of the first things we want them to understand is how all of these domains influence each other. Lack of sleep significantly impacts our ability to recover from training, recover from injury. It impacts our nutrition decisions. Conversely, our stress management impacts our sleep. It impacts our ability to recover from training. And all of these different domains, none of them really live in a silo. We talk about multidisciplinary care, and that looks at different individuals, or different individuals within the healthcare team. When we talk about the individuals we work with in the tactical profession, We really want them to understand how much these domains influence each other. Um, so we're talking about tactical professionals, and the term that gets thrown around a lot is tactical athlete. O2X is a company that serves tactical athletes. I work for O2X, and so my role is to support these tactical athletes. And as we go along, I'm probably going to use the word tactical professional more than tactical athlete. But you know, where this model came from, this tactical athlete model, is from years of looking at the sports medicine model and the multidisciplinary care, looking at those same, 5 different domains of nutrition, mental performance, resilience, mental preparation, mindset, conditioning, all these factors that go into, the demands that our athletes have. The same factors affect our tactical professionals, but there are differences. Um, and so when we look at it, what do we need to consider when I have someone who works, in my setting as a National Guard soldier, whether they're an aviator and they're on a flight crew for a helicopter, or they're a military police officer, or they work on the Homeland Response Force as part of a chemical weapons response team. There's specific job demands that they have that are very different than what our athletes have. If we think about, athletes, I think there's a lot of recognizable people on this slide here. Our athletes, they all wear a uniform. Our tactical professionals also generally wear a uniform. There are, in some sense, predictable demands. When we or predictable demands and predictable rules. So our athletes step on a court, they know when the game is going to start, they know when the game is going to end, they know when they're going to get to rest, how long that's going to last. They know how long or how hard they're going to have to work. They know what directions they're going to have to move and what skills are going to be repeatable for them. When we take a look at our tactical athletes, some of the same principles apply, but also in a little bit of a broader sense, right? So we think about a basketball player who needs to perform or needs to return their performance. If we look at it from a physical lens, we know that that athlete's going to have to do some short sprints. We knew they're going to have to move on a court for a certain period of time. We can take the time to do physiologic and GPS monitoring and say, how many times a game on average does this individual have to sprint? How far do they sprint? How quickly do they have to accelerate for? And we can look at that as repetitive load. How many loading cycles are they going to have? How many change of directions? How many accelerations? Our individuals who work in these service occupations, our firefighters, our police officers, paramedics, EMTs, first responders, and our military service members, they do have specific demands based on their job that they train for. They have skills, right? That's the same sort of tactical setting, the strategy, just like our athletes work on game strategy, opponent strategy, how they're going to match up to the opponent they're facing. Our tactical professionals have specific skills and techniques that they have to learn, have to be able to repeat. But in the real world, they don't necessarily know when their game day starts. They don't necessarily know when it's going to end. A typical day for one of our soldiers could be sitting, quietly guarding a post. They don't know which day, is going to be the day that they take fire or they have to respond to something. They don't know how long that they're going to have to respond to that for. We have a handful of soldiers that have done many deployments overseas in the organization I work with. And when I first got to the National Guard, my initial thought was that I didn't know a whole lot about it because I hadn't come from a tactical setting, but I thought the National Guard's primary role was state missions, supporting state needs, federal needs here within the U.S. I knew about like deployments or activations to Washington, D.C. after January 6th. I knew about coming from Massachusetts, the National Guard being called to work on the side of the Boston Marathon as additional security during the races. I knew about the National Guard going to the border. What I didn't know was the soldiers that did multiple tours of duty in Iraq and Afghanistan, combat tours. And one of the units that I worked with really closely, it was only very recently, after 2 years, that I learned that 60 of those soldiers were on the ground defending the Kabul airport as from the Taliban as they were coming in, as the U.S. was evacuating from all their soldiers uh, and others from Afghanistan. So as that process was happening, our soldiers from the state here, they were responsible for protecting that airport, and those 60 soldiers were on the two last flights out, up until the very last minute. After talking to them, when I learned that, their job, their day, their game day essentially was endless. They are running on very limited sleep, doing whatever job or task needed to be done, and continuing to pursue that until the mission was completed. For these individuals, there's no off season, there's no timeouts. Certainly there are quiet times, but they don't, and you don't always know when they're going to be called upon, or when they're going to have to sprint or run or jump or cover or sit or squat, or how long they're going to have to do that for. So there is a little bit of a difference there in terms of those demands. Other differences we'll get into in terms of the gear, the equipment, and how they have to function on the day to day. Going into that, so these individuals need to be able to perform when they're on the job, right? Just like the rest of us. Right now you're all students, so you go to school, and your job is to perform at school, to be able to pay attention and show up and pay attention in class, to get assignments done, to be able to think critically and grow and learn. And many of you are probably also working jobs in addition to that, where you're also expected to show up and perform, right? Because when we're compensated for our work, that's what we're expected to do. When we look at contributors to performance, there's all these different factors, kind of looking back to those eat, sweat, thrive domains that play a role in how we perform. And we could also switch performance around with injury risk as well. When we look at our soldiers, we talk to our soldiers, our tactical professionals. We're looking at injury risk, recovery from injury, or their ability to perform on the job. We're looking at how they're doing in all of these different lanes. And like you, they have many different demands and stressors probably pulling at them as well. We're talking about, with my population, with my soldiers, folks who work part-time as soldiers for the most part, and then Monday through Friday, or the other 28 days of the month, they work another job where they have to focus on that. Then when they come to a drill weekend, they then have to put their uniform on and be physically and mentally prepared to take on the role of the soldier and their mission set, whatever that may be. And then at the end of the weekend, or at the end of the training period, they go back to their regular job and their regular life. This is an additional duty in and above what they were already doing. For them, we look at what the stressors of their other jobs look like, their and their family, home life, how much time they have to train, how much time they have to prepare. All these things play a role. And so a big focus for us is to help them control what's within their world, what they can control, and make 1% decisions, small building blocks that they can take advantage of to then build on from there. Tactical professionals, so outside of the court, they can operate in any environment. A basketball player is going to play on a basketball court. A swimmer is going to swim in a pool. Firefighters are going to have to deal with additional gear. They may wear, their suits, their fire protection suits, wear an SCBA, have a heavy tank on their back, helmet on their head. Police officers may have to wear their kit, body armor, vest, belts, pistol on one side. All these things impact their body mechanics. They may have to operate in different environments, whether it's on the street, in a building, in the woods, in light or dark environments. You may have to work very quickly, or you may have to work for an extended period of time. If anybody's ever, I'm sure most of you have taken a CPR course. I don't know if anyone in the group has ever had to administer CPR, but when you have to administer CPR for minutes on end, it becomes very exhausting and taxes on our energy systems very quickly. Or you may have to work with individuals, whether they're conscious and responsive, conscious and responsive, whether they're violent or unpredictable, or whether they're unresponsive. All of these other factors come into play when they're on the job, and we need to be able to consider that for them. So with the Army, with my role specifically, we have a program at the Army called H2F, or Holistic Health and Fitness. This is an outroll of the classic sports medicine model that the Army started back in 2020. So the sports medicine model, we're looking at putting athletic trainers, physical therapists, registered dietitians, strength and conditioning coaches, and sports psychologists within that sports team. The Army took that model in 2020 and they implemented it across 26 active duty brigades. They also funded the Army Reserves and the Army National Guard to pilot this program, which is how I got to be able to work in this setting. In Massachusetts, the last 5 years and 3 for me, they've been feeding information back to active duty and the National Guard Bureau as to how best to administer this program. The Army focuses on 5 domains, matching up with a lot of those pillars of performance we talked about before: nutritional readiness, physical readiness, mental readiness, sleep readiness, and spiritual readiness. We fall snugly under the physical readiness domain. Couple concepts we have to keep in mind when we're working with individuals in a tactical setting is humans over hardware means 2 things to me. This concept came up at first when the chief of staff of the Army brought up the fact that the most important, the most valuable weapon system that our military has is the individuals in the uniform. The most important, most valuable thing that we have, despite the millions of dollars they spend on equipment, research, and design, is the humans, is the individuals. And to take that one step further, when we're working with individuals in this setting, we have to remember that they're not just hardware. They're not just a machine. They're individuals. They have a number of different stressors. My soldiers have home lives. They have other work lives, whether that be a police officer, firefighter, teacher, physical therapist, lawyer, laborer, or they're unemployed. Each of these individuals come from very different backgrounds, have very different demands, and a number of different stressors pulling at them. And success from an outcome standpoint for them to be able to navigate injuries, stay healthy, and finish their career stronger than they started. If I'm going to be able to help them, number one, I have to be able to understand, who they are and what's going to help them best meet that goal. Second, we're all made of the same stuff. So, whether you're a $30 million a year baseball pitcher, or you are a forward observer from the field artillery. We all have bones, muscles, tendons. We're all made of the same things. From a starting point, when we have an injury, we have something that we have to navigate and deal with, the basics are always the basics. It always starts the same way. When we start to go beyond that and really have to consider what those demands are, now we're looking at return to duty kinds of considerations. So how much time is this person able to take off? What does their operations look like? Are they able to take time off? How does that fit in with the nature of the injury they're dealing with? And what tasks do they have to do? What time requirements do they have? What kinds of loads are that going to put on their body? Are they going to be able to handle that? If they're able to train in a modified status, how do we adapt their training to meet what they need so that they can recover? Excuse me, if they're in a forward deployed type setting, and we do work with individuals that are we call downrange or deployed overseas, are they able to continue to perform over there? Can we help them continue to perform over there? And what resources on post are available to them that they can take advantage of? while they're deployed. Lastly, what kind of equipment and gear, what are those external loads that they're going to have on their body or around them that they're going to have to be able to manage? In the National Guard, my team comprises of 3 individuals: myself, head strength and conditioning coach, and a registered dietitian. For that, we have 5,500 soldiers and about 3,000 airmen. Because the National Guard is primarily a state program when they're here, we support both sides. So we're looking at over 8,000 individuals between the 5 of us. Organizationally, there's 5 different commands within the Army National Guard. We have all different job subsets from recruiting to infantry and field artillery and special forces unit to engineers, military police, transportation, truck drivers. We have maintenance, vehicle maintenance. We have our aviation unit, the Black Hawk helicopter teams, their crews, their maintenance. With the civil support team, which is a police unit. We have the band, we have the chemical unit, fire department, and they train at over 60, it's almost 80 training sites across the state. On the air side, fortunately, the 3,000 airmen are split into 2 locations when they do train. That's our fighter wing. They do have a fly mission. It's really cool when you hang out with them because the jets are always taking off and landing and doing exercises around you. And then the intelligence wing, more of a sedentary type mission. So coming in this organization, we don't have one sport to learn. We have to learn all the different demands of the different individuals. Of those 8,000, or if we look at just the Army National Guard, less than 5% work full-time jobs. Full-time soldiers are there all the time. They keep the ball rolling when everybody else is at home. The remainder, they work in an M-day status, or drill status, where they drill 1 weekend per month, 2 weeks out of the year. And at my expensive, the constant headache that I have, they are geographically dispersed, which means that they are not always easily accessible for me. And that doesn't just include where they live around Massachusetts, Rhode Island, Connecticut, New Hampshire, Vermont, and New York, but also their deployments, which could be here within the US or outside of the US. We currently have deployments in Africa, Europe, and in the Middle East, as well as their state and federal activations. So we have soldiers who might be called off their regular jobs to work the current migrant missions here in the state, and support that, or supports events like the Boston Marathon or other security events, to federal activations where we have soldiers that may be called for different needs. I mentioned the January 6th activation, so our soldiers from Massachusetts were down in DC for that. We also have soldiers that they're activated working different jobs around the border. Potential issues from my lens as a physical therapist, when I look at these individuals with all these different jobs, different demands, and not a whole lot of time to prepare and train for it, is, well, they're off in between drill. They take the uniform off and they go back into whatever job they have. So they have access to me in person when they're on drill. If I'm at their drill for the next 30 days, we're going to have to figure out a system that we can continue to work together if that meets their needs. In the active duty, they get PT time, or what's called physical training time. The rest of the world, most of them call it occupational fitness time, or OFT. The active duty soldiers get to train every day. Our soldiers have to take a physical performance test, and they don't have time during their regular jobs in order to train. So in addition to whatever life stressors, life demands, or responsibilities they have, in order to pass a PT test or to stay physically prepared for any of the demands that they have on the job, they have to find additional time Monday through Friday in order to get to the gym or work out from home or go for a run or do whatever it is that they need to do to be prepared. We also deal with budget and time constraints. Budget and money is always an issue for funding National Guard soldiers training, and so that creates access issues for them, as well as training time constraints. So I may plan to meet with a soldier, but they may be expected um, to do certain tasks within a certain amount of time that makes that very challenging. Um, Kind of along the same lines of a time off between drill, a lot of the work we do is remote. Because our soldiers don't have easy access to me. It would be a lot to ask a soldier from, say, Western Massachusetts to drive 2 hours to me during the week to be able to meet. Um, Lastly, what do they have available for facilities and equipment? Uh, so my role there is kind of broad. As an injury risk reduction specialist, we're, primarily it sits in a physical therapy role where we provide care both in person and remote via telehealth type model. In addition, I lean heavily on the CSCS and the USA Triathlon endurance coaching and training to help our soldiers better prepare. We can layer the preparation aspect into their training or layer the fitness aspect into their reconditioning or return from injury, we could potentially accommodate a lot of the injury risks that they might see. So that includes group training sessions, remote coaching, unit PT. Unit PT means we lead a training session when we go to drill. Reconditioning means we help soldiers who are returning to duty after an injury. And then we also have physiologic testing capability through our metabolic cart at our headquarters office. So we do bring soldiers in for different needs to do some performance testing on that side. Unit collaboration means we work with not just the individuals, we work with their commands and their leaders, the folks who they're responsible for reporting to and who are tracking whether or not they are able to be functional in their job. We work with their leaders on their physical training when we're not at drill. Again, there's 3 of us and over 60 training sites. So when we're not there, they need to be able to carry this on. They are expected to do that. And so we work in a role to try to facilitate that and help those units be better prepared and lead their physical training and injury prevention lens a little more appropriately. When we do go to drill, we do a lot of classroom education with our individuals, whether it's training related, nutrition, or injury prevention. And then we spend time with our soldiers when they do go out into the field. So when they are training, when they're in the woods, when they're working with their equipment, we spend time with them. That includes training observation. What are the tasks? What are the demands they have to do? What does that look like? And then discussing that with them so we can learn better how to help them. Facilitation, that fits back into the physical training side of things and working with the command staff. So we work with master fitness trainers, which are folks designated within the formation or within the force to help other soldiers or their unit, prepare as best as possible. We also facilitate the Army body composition programs. The Army does have body composition standards, as well as the Army combat fitness test. So their physical fitness standards, which we'll get into in a second. We help those units identify the issues that they have in those areas, and then help provide solutions for them. We also do data collection, so everything we do gets recorded, measured, and then we report back. From a reporting standpoint, just jump ahead real quick. We do all of our standard PT documentation as well as our physical restriction profiling, and then we report to a number of different levels of the organization. So we're constantly in meetings, constantly providing data back up the chain, just like we would in a sports medicine model. We're reporting to, say, head coach, general manager, hey, these are the things this player can do. These are our recommendations. We do the same thing with our leadership. So we go to the organization, whether it's a company, a battalion, the state, or even the federal level, we're constantly reporting what our state metrics looks like in terms of physical ability to perform. Going back, I want to highlight kind of quickly as best as possible what our patient care model looks like, especially since a lot of it is remote and through telehealth. So number one, we should always start with an intake call, and working with our team is always voluntary for a soldier, but they'll reach out, and it starts with an intake call, which provides an opportunity to get some background and do screening for referral and for appropriateness. So that starts with our deep subjective component of our evaluation. We spend a lot of time talking to them about what's going on, what their needs are, what medical care they've had. and starting to create a picture of whether or not this is a scenario that we can manage remotely through a hybrid setting where we meet with the individual once, twice, a few times, and then provide direction remotely beyond that. So we're really trying to assess whether or not that's going to fit well for this model. The things that we see mostly, a lot of overuse training related injuries, tendinopathies, stress fractures. We do see low back strains. We see a lot of recreational injuries. So folks who play, pick up sports or play with their kids, work around the house. And we see a lot of the common injuries that go along with that. Well, soldier will sprain an ankle playing soccer on Saturday, reach out to me on Monday. Hey, this is what just happened. What are my best next steps? This is the opportunity to screen, use the uh, clinical prediction rules. Is this somebody that needs to go and see a doctor? Do they need an X-ray right now? How do we go from here? So we go from the intake call off into an initial session. If they're local, we can actually do an initial session in person, just like we would in the clinic or in a training room and athletic setting. If we're not local, that's going to happen, over a telehealth video teleconference type of call like this, where then we're going to move forward with that baseline. So we're going to get a little bit more information from that. We've got different models for how we can assess through that, and then use that as our foundation from there. Communication is a key component here. So as we're assessing, as we're kind of establishing our opinion, our thoughts on what's going on with the individual, we're discussing with that with them so that they understand exactly what is going on. There are a lot of moving parts in the Army. The last thing they need is unpredictable care or communication from us. So we want to make sure they're getting everything that they need to be in a position to take care of themselves through whatever aspect of that care is going to be their responsibility, right? If it's their home program, if it's managing pain symptoms, if it progressing something individually or helping them understand how to regress when they have to. We're covering all of that in a lot of detail with them. So one thing that's nice about this is when I do these consults, we're not typically limited by time. We have the ability to make sure they have all the tools they need going forward. And then we discuss what the expectations are so they know what to be doing. They know what they might see or what they might not want to see over the next, say, 24 hours, 3 days, to a week, or however much time goes between our current call and our next call. From there, they're a huge part of creation of those long-term goals and the short-term goals. Because if we're working remotely and I'm programming for them, from behind my computer screen when I'm not with them, they need to know what to be on the lookout for. They also need to know what they can be testing on a daily or weekly basis as they go forward. And if they're not seeing what they want to see or should be seeing, that's a prompt for them to reach out to me. So if we've decided, hey, we're going to have a call in 2 weeks, here are your lefts and rights. Here's the goal you're trying to hit. If you hit it early, let me know. If you bump into these guardrails on either side based on these outcomes that we see, significant increase in pain to a certain point, loss of range of motion, swelling, whatever parameters we set on that, they see those, then we know we're going to course correct or change what we're doing. So we have the ability to adjust on the fly in that model. This is really how we kind of operate. We do a lot of telehealth. See a handful of soldiers, many of those soldiers on a hybrid setting where we do a lot of telehealth, but then we get an assessment in person. It really varies individual to individual based on their schedule, location, and availability. There are 3 tiers to injury risk reduction in the Army, as were pointed out by Malloy in 2020, and we've modeled our program after this. So one of the things that Malloy highlighted was that non-combat musculoskeletal injuries account for more than 80% of soldier injuries and 65% of medically non-deployable active duty soldiers. Non-combat related injuries, musculoskeletal injuries, account for more than 80% of overall soldier injuries. Most of these are going to be training related overuse or acute injury. So it could be overuse, whether it's their physical training, or it could be acute injuries, or it's an ankle sprain because they're marching and working in the field, they're working with heavy equipment, it could be a low back injury. But these are injuries that we can be looking at and tracking, measuring and looking for ways to try to either reduce the risk for these happening or reduce the impact when they do happen so our individuals can get back to work. Those tiers, starting with the obvious primary injury prevention of decreasing the risk for musculoskeletal injury. Let's see what we can do to decrease that in the first place. Second, decrease the impact of existing musculoskeletal injury. So my soldier is dealing with an injury. From that point, how do we reduce the impact on their function while they're doing this? And then lastly, how do we limit the long-term impacts of certain injuries that they might deal with? From a decrease in risk standpoint, it helps us to know what those injuries are that are most common for individuals. What types of tissues are most common? What are the mechanisms that are most common? Are they overuse injuries? Are they tendinopathies? Are they muscle strains? And so in our case, we see a lot of knee injuries as far as body region. We see foot and ankle, and then low back, and then hip and shoulder. And that lines up very consistently with the active duty component sees, mostly on the knee side because our soldiers spend a lot of time on their feet. They do a lot of transitions from kneeling to standing to squatting, a lot of load carriage on their back where they're carrying heavy loads. And running is a common aspect of physical training. So because of all these different demands, we often see a lot of knee injuries, foot, ankle, and then low back, and then moving on down the line. Risk factors that we see that we want to address are most commonly we're seeing a change in activity or change in training load. This is most common for our soldiers when they go home after a drill and they don't train or they don't do anything similar to what they have to do when they show up. This would be like along the lines of not doing any running for 30 days and then signing up for a 5K or a 10K or potentially a half marathon every, once a month. Eventually, something is bound to happen in those situations. Previous injuries, the other risk factor that we see is very common, and it's injuries that we've had before, whether it's a re-injury of the same issue or it's an injury to a tissue above or below. And then lastly is controls for what exposures do they have, whether it's exposures to heavy equipment, exposures to repetitive movements, prolonged positions. One of our units did a training in at Fort Drum, and it takes 15 hours for a convoy to move from the Boston area to Fort Drum in New York. That's a lot of time sitting in a vehicle, and then looking at vibrations, which a lot of our vehicle operators and aviators have to deal with, is repetitive vibrations. So from an intervention standpoint, what do we have to look at that? So the Army's implemented their occupational physical assessment test and the Army Combat Fitness test. They've updated their doctrine on physical training and preparation, which is an area that we play a big role in. And that's come through the H2F system, so that holistic health and fitness model, updated that training doctrine in order to improve the physical training, injury management aspect of care for our soldiers. And they're doing a better job of looking at who's at risk for injury with certain jobs through that occupational physical assessment test. And they've recently changed their physical fitness standards to adopt a little bit more of a sports medicine model. The previous test used to be sit-ups, push-ups, and run. Now it includes a battery of 6 different assessments, and we'll get into a second about what that would entail. We're also looking at changes in footwear, equipment that they have, the gear that they carry, as well as the environment that they're operating in and how they're preparing to be in those environments. Our soldiers, I said, they're responsible for a number of different demands. They may have to sprint, they may have to move on foot for long periods of time, they may be confined to a seating position for long periods of time, operating with heavy equipment, or carrying heavy loads on their back. And all of these place a variety of physical demands on the body. Equipment alone is probably one of the greater risks that soldiers have. There's a number of different reasons, from helmet, headgear that impacts cervical range of motion, field of view, adds additional weight on top of the head. When they add on their nods or their night vision, that adds additional weight. It's constantly pulling them into a bit of a flexion moment, and so they're working their spine, their cervical spine, harder for longer periods of time when they're using that equipment. They're often weighed down by their fighting load carrier or their flick. That's going to include a number of equipment that they're carrying that might have body armor underneath it, canteens, food, weapon systems, survival gear. They're constantly weighed down, and then depending on their mission set, they may be responsible for carrying anywhere from 10 to 20 up to 100 pounds or more on their back. For our special forces soldiers, it's not uncommon for them to be between 80 and 100 pounds for extended periods of time. The standards for many of our physical fitness tests include carrying 35 pounds on their back for up to 12 miles. And depending on the standard, that could be at a pace of anywhere from some sub 15 minutes per mile to sub 17:30. It's a pretty brisk walk under load in boots with heavy restrictive gear on. From a physical assessment and preparation standpoint, the Army's done a great job of broadening their Army combat fitness test to look at physical tasks that soldiers might have to perform. That includes a 3-rep max deadlift and being able to lift a weight from the floor to your waist. From an explosive standpoint, they look at power through a medicine ball throw, but they're also looking at, if you can see the ball throw, right, range of motion on this. The ability to perform this test well is also going to look at tie into your ability to get into your total body extension, ankle plantar flexion, hip extension, low back and thoracic extension, full shoulder flexion. So a lot of range of motion that goes into performing this test adequately. The hand release push-up is an interesting take on the push-up. It matches the functional movement groups, trunk stability push-up, if you've ever seen that. So incorporates the spine stability or spine stiffness into that as well as a test of upper body endurance. The sprint drag carry looks at a number of different locomotor qualities, from running to backpedaling with weight to carrying weight. So it starts with a run, then you move into reverse sled drag. You move into, from there, it's a lateral shuffle, farmer carry, and then another sprint. So we're looking at locomotor qualities, but we're also looking at anaerobic performance. So we're looking at a tested energy system as well. Plank for trunk muscle endurance, and then our 2-mile run as our aerobic standard. So you're looking at everything from all 3 energy systems to muscle endurance, strength, power, and various locomotor qualities. So we're looking for our soldiers to be able to do all of these things. When we're designing rehab and reconditioning programs, we're often utilizing these tests as part of our long-term goals and part of our programming as well, whether it's a modification of a test or working towards specific aspects, being able to use a certain percentage of a previous weight, a certain time, a certain pace, a certain load. These things can be both the test or the measure for our soldiers in the long run, but they can also be prescriptive for us from a programming standpoint. Anytime we're working with a soldier, we're looking for what individual risk factors they have, or one of our units. So if we have 60 soldiers that have the same job, what are the job demands and the risk factors there? What needs do they have? And then what barriers do they have to being successful there? We make a plan, we help them with those 1%. We take action, and then we're constantly reassessing and teaching them how to go through that process themselves. Again, the 3 of us are trying to facilitate this process for the organization as a whole. Number 2, I think this is a really important one for us and highlights what we're doing here. So decreasing the impact of existing musculoskeletal injury. Um, this includes embedding physical therapy resources um, downrange with our soldiers, but also within, within their operational footprint. So around the soldiers on a day-to-day basis, it means being involved, being a part of the team when they're training. Might not be training with them, but you're always available to discuss, to talk, to learn from them, and to help them improve from there. The number one highlight this has, it helps soldiers build their trust for you as a provider because you're there with them often, and it provides an early access point for care. Research in a number of different areas often shows that it's beneficial to have um, early access to care, early mobilization, better functional outcomes at an earlier rate. So in this case, if our soldiers have an injury or something they bring up at drill, they're able to talk to us or know how to get to that resource the following week rather than waiting for a while to get started. And particularly if they're leaning on their military healthcare, there can be a lot of steps, starting with their leadership, then moving on to the medical command, and then moving into the healthcare system. It can take weeks to months for them to get access to healthcare, so we can help them start that process right away. Um, let's see. So moving on to looking at those long-term effects, that last component of injury risk reduction is looking at those metrics, helping the leadership better understand what factors play a role in those injury risks and performance demands. For on our end, being able to track those and provide those metrics for them. So being able to facilitate that. We use the profiling system, so that's our physical work restrictions that we provide for our soldiers. And that includes whether it's the ACFT to how much weight they can lift, how long they can wear gear for, what kind of demands they can face. And we really focus on what we call positive profiling. It's not uncommon for soldiers to receive a profile and for their mindset to shift and say, well, now these are the things I cannot do. Our profiling model looks a little bit looks in completely another direction. Our focus is on these are all of the things that you can do, and helping them figure out where they fit in into their unit, what they can do from a training standpoint, what they can participate in, and then taking the opportunity to modify that on an ongoing basis so that we can continue to add um, new abilities or new performance characteristics for our soldiers as they're going through that process. Um, Unfortunately, some injuries do necessitate a change in status for the soldier. It is a physical job. It does not come without its risks. And, some of the jobs do require us to absolutely be able to meet certain physical demands. And along with this H2F model, the Army has placed a large amount of value on the long-term health of their soldiers, not just during their career, but after. And so this has led to an increase in repositioning of soldiers, so moving them from one job set to another, retraining them rather than saying, hey, you're no longer of use to us. They can better retain soldiers by helping them find if they can't do jobs within the military they can do, and then providing a pathway for them to retire medically if necessary. Just want to highlight a couple of the ongoing initiatives we have. The number one and most important initiative we have is the recruiting and retention battalion. Soldiers' first year in the Army is when they're at the greatest risk for injury, and injury during the first year of a soldier's career is the single greatest risk factor for early separation from the military for a soldier, meaning a short career. And if your goal is to use the Army National Guard for, say, your education benefits, separating early isn't necessarily a great thing. We want to keep our soldiers in as long as they want to or need to be in. We wanted them to be healthier when they finish their career than when they start, if possible. So we start with our recruiting and retention battalion when our soldiers sign their contracts. They start to drill with this unit every month. And there's 3 of them around the state. We have a presence at every month. And our goal is to help them better prepare and better understand the demands that they're going to face during basic training and AIT. AIT being their advanced training for their job setting. Most commonly, we see tendinopathies and bone stress injuries during these trainings, and that's particularly during basic combat training. Uh, and what we're seeing again, so injuries during this time lead to early separation. That tracks with the last 3 years. Our soldiers are educated when they're there to just push through because the soldier sometimes has to just push through. Active duty soldiers get to go to their unit and then get access to physical therapy care and guidance, whether it's through H2F or through the medical system that's available to them. Our National Guard soldiers come home and are sent to their unit and aren't often given guidance on how to navigate that. And so we tend to see these injuries or their complications linger for longer periods of time. This is where I spend a lot of time with soldiers that have been here for more than a few years. Often the hand comes up, hey, I had a stress fracture at basic training 3 years ago, and I have had hip or low back or knee issues since then. Same thing with tendinopathies. We see a lot of these injuries that come that tend to then become long-term issues for these soldiers. We also work with our officer candidate school. So enlisted soldiers that want to be new leaders go through officer candidate school. We provide education and training for them throughout the different phases. The OCS has some very demanding physical gates as well as a very physically taxing phase when they start. Most of the soldiers drop out because of overuse injuries during this phase. Most of the soldiers show up unprepared to work as physically as they need to. And so our education on that, our implementation has been working on leadership to help the new candidates prepare for the school so that they can be successful. When they lean on that, when they're successful, they go to their new units as leaders and commanders, and they have the opportunity to then share that knowledge downward to the soldiers that they're now responsible for. And that education goes outward throughout the population of the state. Lastly, we support a number of different training operations events. Our soldiers that want to do specific schools, specific trainings. We coach our soldiers. I coach soldiers for the best work competition, as well as the National Guard marathon team, endurance team, rugby team, and biathlon. So a lot of different athletic components going on here as well. So that kind of highlights the role of working with tactical athletes or tactical professionals, particularly through the lens of the Army National Guard, which comes with some very specific challenges that the active component don't have. I apologize if that went a little bit long for you guys. There's so much to share. I really enjoy it and I'm very passionate about it. So I always want to talk about all of the things. But yeah, I'd like to know if you have any questions or anything you'd like to discuss further.
That was great, Joe, and it was not too long. Thank you so much. If anybody has a question for Dr. Cavallaro, please feel free to use the raise hand function, or you can put it in the chat, or you can direct message it to either myself or Dr. Aosa, and we'll try to ask the question. I see one hand. Sandra?
Yeah, so what does I know there's a lot that you could probably say for this, but what does like an average day in the life or like week in the life kind of look like, doing physical therapy in like this field?
That's an awesome question. I could talk first to what I do, what it looks like with the Army National Guard, and then because I have a number of colleagues that work in some different settings. I can talk briefly about what their day or week is like. I have no 2 weeks that are the same because uh, with the 60 plus different units, they train at different times at different locations on a different schedule. And so when they drill, that involves travel around the state, often driving to different armories or training sites. And that could be in inside of an armory, inside of a building that looks like a 50-year-old elementary school cafeteria, or it could be out in the woods. I mean, I would go out into the woods with the soldiers all the time when they're training. And that might mean training with them, might mean walking through the woods. I have slept in the woods with soldiers during training. And then during the week, it it looks like a combination of things. So I would say I probably spend um, I probably see on average 10 to 15 regular patient visits a week. But I have currently about 70 to 75 individuals that I'm working with. If you put it in clinic math and just say like an average of 2 visits per patient, that's 150 visits per week. So my total visits are usually low. My total sessions are usually low, but they're a little bit longer and more in depth. In between, uh, I have weekly check-ins. So that could be through the app that we use where our soldiers have a messaging portal to contact me, or it could be through email. And many of my soldiers just have my phone number and they just text me. So there are weekly check-ins that are a part of our process. I probably average 3 to 5 one-on-one sessions total with a soldier, but that could be over, that could be in a month, it could be six months. So in between, I write training programs, just like a remote strength and conditioning coach might. Um, but I program on a very short-term basis. So it could be 1 or 2 weeks at a time that are written out. And that's their home exercise program for them. And then I review their results. They're given again as part of our evaluation process, a lot of those lefts and rights. So there's specific things that they have to be watching out for that I would be watching out for. I want them to know that in advance. And I always have a lower threshold for them than what I might have for myself, like if I have eyes on in the clinic, because I want them to communicate with me. Then we can have the discussion, say, hey, is this something that we need to deal with or not? So it's 10 to 15, visits, regular visits. It's reading, reviewing, and updating training programs that are usually updated a few weeks at a time. It includes a lot of meetings. So all of those like reporting requirements I talked about, leaders from these different commands need to be updated on what we're doing, and then we participate in their training and planning meetings. So there's a lot of boring time. I find it interesting because I like to know what they're up to, but it's definitely a lot of tedious time where we're sitting in the back of the room listening to them discuss what their movement, their convoy operation is going to be from one side of the state to Cape Cod, which is a lot to sit through and listen. One of the benefits I get in this role as a contractor is I work 40 hours a week for the Guard. So when I work all day on a Saturday and Sunday, I will take a Monday and Tuesday off. I don't work every weekend. Sometimes I work 3 weekends in a row. And sometimes, it's just one weekend or a day a month. But then I get to flex that time. So I get a little bit of time back during the week, which my son is too. And it has actually been awesome to be like spend time one-on-one with him during the week. And just to have that time when maybe he would have been with a babysitter or like a family member. So there are some trade-offs on that one. My organization is unique. I know some of the folks that work at the fire departments and police departments that I work with. Theirs are similar, but they're more Monday to Friday. and their travel just involves going to the different stations or different houses.
So I have a question from the chat, because we have talked in some of our classes about how the Army model actually allows physical therapists to order testing or imaging that physical therapists in standard clinical practice can't order. So the question is, because you're working with the Army National Guard or the Massachusetts National Guard, can you order imaging or other tests?
So currently, I cannot order imaging or other tests, or do any kind of prescription for medications. Now that is common, that is for physical therapists in uniform to do that in the Army. It's also something that civilian physical therapists at what they call military treatment facilities. That's usually a hospital on base or the MTF. So civilians and contractors who work in those roles can do that. Most of the folks working in the special operations units have that ability, because the National Guard is still has been part of a pilot program. We haven't been granted all of the same permissions, and there are certain challenges that we have. We are looking at fiscal year 26, so starting October of next year, for the H2F program to become an established program of record at the National Guard. At that time, we would be looking at what the credentialing processes would be like for some of those components. But currently, at the National Guard, we don't have that ability.
That was a great answer. Thank you.